Welcome, everyone. We're welcoming you to an Apex Biologics two-part webinar with Dr. Jason A Piraino. We are delighted to have everyone here as we dive into today's topics. We want you to know that your participation adds great value to the session. Please feel free to engage with questions or thoughts throughout the session via the chat feature in the Q&A section. Let's make this a valuable experience for everyone. The first portion of this series will focus on augmenting your clinical practice, novel approaches to common foot and ankle conditions with innovative autologous biologics. Ladies and gentlemen, it is an honor to introduce our esteemed guest for today's webinar, Dr. Jason A Piraino, DPM, MS, FACFAS. He is an associate professor and chief of the Division of Foot and Ankle Surgery at University of Florida College of Medicine, Department of Orthopedic Surgery and Rehabilitation in Jacksonville, Florida. He also serves as the residency director for the University of Florida College of Medicine, Jacksonville Podiatric Surgery and Medicine Residency. He has received multiple awards for excellence in teaching at the University of Florida College of Medicine, Jacksonville. He was recently appointed to the American College of Foot and Ankle Surgeons Board of Directors. He also has a unique perspective in product approvals, as he has served as chair of the Value Analysis Committee at UF for the last 10 years. Without further ado, let's welcome Dr. Jason A Piraino to share his valuable insights with us. I will now pass the time over to you, Dr. Piraino.
Thank you very much. Can you hear me?
Yes, we can.
Wonderful. Thank you so much for having me. It's an honor. I hope I can live up to all those things you just said, but probably not. Disclaimer, I just had a 3-week-old child, so I'm running on fumes here. Those of you that have done residency, I feel like I'm a resident again. But anyway, so this is a 2-part series. The first part's going to focus on more non-operative benefits of PRP and other products that Apex has to benefit your outpatient practice. The second part is a little bit more geared towards operative and includes an additional product that I probably won't be talking about in the beginning here. So let me just go ahead and share my screen. All right, can you all see that? Perfect. Yes. All right, that's one of the longest titles I've ever put on a slide deck, to be honest with you. I had to move things around to get it in there. So I'm always learning. I recently took an education class actually for the AO group. You're never too young or old to learn something new. And so they require you, in order to teach at AO, to take a learning seminar. And it was very, very interesting because they talked about how to build a PowerPoint. And you're sitting there going, I've been doing this for 20 years. I know how to build a PowerPoint. And then you realize, maybe I don't, because learners are very different. But the one thing I took many things out of it, but one of the big things I took out of it was this slide right here. So this is the most important slide of the presentation, because not only because it's funny, but because it gives a rundown of what I hope that you'll get out of this lecture. So we'll talk a little bit about the science of healing, but probably everyone on here understands and knows the biology behind it. But I do want to touch on a little bit more of the advanced aspects of what Apex has to offer when it comes to PRP. So it'll be a kind of a shorter course in that. And then we'll talk about PRP. So what Apex has to offer, why it's a little bit different, what else can we get from the PRP? And then the kind of the bigger portion of this discussion will be when and where should we use it in our outpatient clinical setting. And then along the way, we'll talk about some of the literature that's out there. It's kind of all over the place, and we'll kind of get into that in a second. But hopefully you get out of this that, not all the PRPs are the same. Apex is a little bit different. When you can use it in the office, how you can use it in the office, and then what you can tell your patients. The literature is important to me because, A, it gives basis for doing procedures and injecting things, but also it can be valuable information for your patients. So a lot of times, you'll get a lot of distinct questions from patients that want to know, and they're poignant, and they can go do the research themselves sometimes. So you want to be prepared. So we'll start off a little on the boring side. The 4 phases of healing. I think we all are familiar with this. Similar in almost anything. So you have coagulation, you have inflammatory, migratory, and then remodeling, and then the cells that are involved. So platelets are initially involved in the coagulation phase, and then they kind of push out, and then kind of also in the inflammatory phase, and they can release growth factors. And I think everyone's on board with that. The interesting thing, if you look up PRP, anyone could publish that they have PRP if it's because it's defined as any increase of concentrated platelets over serum baseline. So that could be anything. So you just have to be careful with what you're injecting and understand that not all PRP preparations are and will be the same. They differ based on percentage of platelet recovery, how many red or white blood cells are available. If there's back in the day, if those of you that have been injecting PRP for a long time, if you remember, they used to add thrombin. They don't do that anymore. This is an older slide, but and then level of fibrin formation. So once we spin down the blood, we end up with 3 distinct layers. So the plasma, the buffy coat, and then the RBCs. And then you have a little bit of overlap if you've ever seen this kind of live. It's kind of neat. It looks like one of those bubble things that you can kind of see the layers when you layer out vinegar and oil, and you can grab whatever you want. The really interesting thing about Apex's PRP system, which I'll get into in a second, is it's kind of inverted from what you normally see. So you pull off that platelet-poor plasma, you can pull off the platelet-rich plasma, and then you can grab a little bit of the red blood cells. Now, in that buffy coat, that kind of inner layer area is where you have the mononuclear leukocytes, your T cells, lymphocytes, and monocytes that are not pro-inflammatory. And then you have the multinucleated leukocytes that are inflammatory. So we'll talk about that here in a second. Platelet-assisted growth factors that kind of the platelets release. You can read it for yourself here. There's a lot of them. This is just a quick list of them. I highlighted PDGF because I think that's one of the more important growth factors that the platelet PRP will release because it helps stimulate angiogenesis and recruits growth of cells. So again, just to reiterate, benefits of PRP: acceleration of healing process, stimulation of mesenchymal stem cells, improvement of microvascularization. And remember, this is autologous. And that's one of the things I kind of talk to my patients about in the clinical setting is, yes, we can inject a steroid. And yes, it's covered by insurance, but it's also not your own. It's much safer to inject autologous substances rather than substances that came from a vial. And I don't know if anyone heard about the issues they had with some of the steroid that had come from Boston that was contaminated. But you don't have to worry about things like that typically. So Apex designed their PRP system, their XL PRP system with the physician in mind, so it and the patient in mind. It allows you to kind of dial in either if you want leukocyte rich or leukocyte poor PRP, which is wonderful. Those of you, again, that have been doing this for a long time know that when PRP first came out, everyone was against using leukocyte rich. So no one wanted the white blood cells, no one wanted the red blood cells, they just wanted the PRP. And what we found over a course of time is that that's not always the case. Sometimes we want leukocytes in our preparation because sometimes we want to stimulate the inflammatory cycle. Now, prior to that, you were telling yourself, no, we don't want to get into that inflammatory cycle. We want to just get the growth factors. Well, sometimes you need that inflammatory cycle to be kind of boosted so that you can get the healing that's needed in a specific area. So again, it's an inverted kind of bench press thing here that they have, benchtop press. So you don't ever disturb the platelets, which is great. And they kind of pull off the platelet pore plasma first, and then you can kind of slowly pull off the buffy coat instead of doing it the other way around. So again, it's a pretty easy system to use, and it's very efficient. So to me, one of the main reasons why, honestly, because I've used all different types of PRP from the very beginning when they first came out with it. And when I first saw this product, the protein concentrate, it was a game changer for me. Primarily because of kind of the highlighted red things here. So basically what happens is when they pull off that platelet pore plasma, historically, we just either tossed it away or kind of injected it. Sometimes you can use it to heal up incisions and things like that. But what people don't realize is that in that platelet pore plasma is a molecule called A2M and IRAP, and then other cytokines and VEGF. And so what happens is Apex has designed a filtration system to filter out a majority of the water that's in the platelet pore and isolate these molecules. The protein concentrate they have is used to counteract the degradative process that breaks down cartilage, and it promotes tissue growth. So A2M is a huge molecule. It lures catabolic enzymes and activates proteases in the joint. You can't reverse A2M, which is great. It's a negative feedback loop in chronic inflammation of osteoarthritis. Catabolic enzymes break down the joint, and A2M migrates to these to mitigate the effects of these enzymes. So basically, it's a sponge for these catabolic enzymes that are breaking down the articular cartilage. So this was really intriguing to me. I know they're doing some clinical research. I know we're doing some clinical research with it. I'll talk a little bit about some of the things we're doing. But this A2M, the interesting thing is if you read the literature, people had seen this a while ago, but what they didn't realize is they were using IRAP. So IRAP was efficient, but not in the literature, didn't work quite as well as A2M. And so now what they're finding is the combination of these things really, really help reduce the degradative process of osteoarthritis in knees. They're researching it in knees in some institutions, and now we're researching it in the lower extremity. IRAP is responsible for binding IL-1, which reduces pain and inflammation. So the protein concentrate, I can't speak more highly than about if there's any reason why you would make a switch, it would be for this reason, because of this product, in my opinion. Also, the PRP is pretty good. So, but anyway, the protein concentrate here, you can kind of see they use this is just the science behind it. This is the pore size of the filter, and it isolates out the interleukins, or the IRAP and this is just kind of an example of that. This is in our office. This is our wonderful rep, Rebecca.
You'll see the water.
And watch what happens. It's kind of neat. You kind of start to see the water collect at the bottom as they pass it through the filter.
Like super concentration.
And it concentrates this.
Vodka.
Disregard what you said. It's not like vodka. Anyway, it kind of does
You'll
look
still
like,
have more than you need for what you're doing, but
you can kind of get the idea of what's happening here. So numbers in PRP do matter. So we'll kind of shift gears to the PRP. So volume and platelet count of the blood input. This is a kind of a graph. What you want to look at is the percent recovery of platelets and the total number of platelets returned, that it actually increases with PRP volume. So essentially, enrichment tells you how much better the PRP is compared to blood for any PRP volume. So having 3 milliliters of a 10x PRP is not better than having 6 milliliters of a 6 PRP. So you're trying to compare apples to apples because it gets confusing. And trust me, I've been, you look at the numbers and you're like, what? So in order to have an apples to apples comparison, you have to consider the volume and the platelet count of the input blood. So platelets in, and the volume and platelet count of the PRP out, platelets out. And so what you'll see here is adding more volume increases total platelets and adds more growth factors. You can also add in your A2M and IRAP through the PPP to enrich your PRP. So this is a graph of a double spin of the leading brand. I kind of put someone else in there at the bottom there, but you can see Apex's XL platelet enrichment is 8.9. It's basically nine times baseline with a 71% platelet recovery, which is huge. So you're talking billions and billions of platelets. So the average platelet count is 1.2 million per microliter, which is basically 1 billion per microliter, which equals an actual dosage. So if you're looking at about 6.5 milliliters of PRP, it's about 7.8 billion platelets, which is a lot. You can see the next leading competitor. I used Arthrex. They were very good. Their concentration was 7.3 times with a platelet recovery of 49%. So you can see it's very different, and no one's caught up to Apex's system just yet. Hopefully maybe they won't. I don't know. So in summary, the Apex system is affordable. If you have any questions, I'll be happy to give my email. You can email me about any type of issues with cost, especially when it comes to value analysis things. If you're on the next one that you want to talk about in the OR, it's very flexible. It allows you to give platelet rich or leukocyte rich, leukocyte poor. Plus, you can use the PPP and get the A2M and protein concentrate. It's efficient. It's got a lot of platelets, and it's simple. So all the things you ask for us as a physician. So let's talk about indications in the foot and ankle, and this is non-operative. So we'll start with bone and joint, talk a little bit about early arthritic changes, and then talk about the soft tissue, which is kind of the meat and potatoes, I think, of most of our practices. But I think this first category is something that kind of gets overlooked. And with the advent of this protein concentrate, it has significantly added to my practice. So what I found was, and what we're kind of doing a study on, is hallux limitus. So everyone sees hallux limitus. We're not talking about rigidus. Hallux limitus, that patient comes in, the joint's jamming, they're having pain, they're not quite ready for surgery. You're talking about grade 1, grade 2, maybe a little bit of spurring. If you want to get an MRI, you can, and you can kind of see the degradation, but you can see the subchondral sclerosis going on, and you know exactly what's happening. And so you put them in that orthotic, or you do your injection, and they just really don't want to go on to surgery. So with all of these patients, one of the things I always offer, kind of along my algorithm, I'm sure everyone's got an algorithm out there what they do, especially for like plantar fasciitis. You all probably have it down pat for that. And the question is, where does this come into play? Well, to me, this comes into play in the same discussion with the steroid injection. So, the discussion is, do you really want to put a steroid in your joint? Yes or no? And you can, it's covered by insurance, or it depends on your patient population if they're willing to pay. Most of the patients, we have an interesting kind of a dichotomy in our practice, because we have a safety net hospital that's downtown, and then we kind of service the external community, that outlying community suburbs, and get a good payer mix out in the suburbs. So those are the patients that typically will pay for it. It also helps that we charge a lot less than most of the competitors in town. But because the system's relatively cheaper than a lot of the other systems out there, you can charge less if you wanted to. So anyway, so typically with hallux limitus, what I'll do is the patient will come in, we'll treat them conservatively, they come back, they're still having pain, I'll offer them an injection, and I'll explain to them, hey, listen, this may be headed down a surgical pathway at some point in time, not like tomorrow, not in a year from now, maybe in like 5 years from now, but there is a newer product on the market that can help reduce the incidence of, at least in the literature, of osteoarthritis in the joint. And most patients are, I give them the literature, they read it, and I've actually given injections of this to many colleagues, physician colleagues. They've watched some of the webinars. I've invited them to watch the webinars, and they're on board. So, educating the patient is, I think, key. With hallux limitus, I typically will do a block. What I found, the first one I did, it was a very nice 60-year-old woman who told me that she had an amazing pain threshold. And when I hear that, it's either very, very true or very, very false. And so it turned out to be very, very false. So we injected her, and you typically have to use a 21 gauge needle, which is not a small needle, especially in the great toe joint. And I try to get at least 2 in, and that's a lot of fluid if anyone is injected into the joint. So usually it's about a 1.5. So trying to put a lot of fluid in there, and she was not tolerating it at all. So the next few times we did it, we certainly did a kind of a block prior to, so that they could tolerate that injection. There is almost no literature on injecting PRP for hallux limitus in an outpatient setting in the office, which is interesting. But we're working on it. We're working on a clinical trial, an investigator-initiated trial here, to see if this, I think it works. I mean, the longest patient we have right now is about 6 months, and I called her the other day just because I knew I was doing this seminar. She's fantastic. She was stage 2. She was having some jamming. We put her in an orthotic, and we gave her this injection. Now you're saying it's probably the orthotic that helped. Well, I'll tell you what, that I put her in the orthotic on the other side, on both sides prior to, and she still had some pain. So it wasn't just the orthotic. So she's doing fantastic. The other 3 patients we've injected also doing very, very good. And again, you're talking about an N of 4, so I don't know. I mean, I'm just telling you what I've experienced, and I'm on board with it, and the science makes sense. The physiology makes sense. So this is why I offer it to most of my patients. So here's Our Lady. That's a lot of PRP in the background there. Ankle arthritis is another one. So there's very good literature on, as opposed to the hallux, to the first MPJ, to use this in ankle. So I usually use leukocyte pore and protein concentrate. We'll use 5 to 7 cc's, as much as we can get in there. And you're talking about a combination of the protein concentrate and the PRP. So it's usually like 2.5 and 2.5, or 3 and 3. Typically don't need a block here because the ankle's not that painful. We've had 3 or 4 patients that have been very good. One of them happened to be a colleague, a neonatologist that I work with. He has an osteochondral defect, has done everything for it. Like you talk about everything, has done everything for it. So I said, let's just try this. And he said, okay. We did him probably about 2 months ago. He's been pain-free. He's like, swears by it. So, knock on wood, he's doing fantastic. The other few patients that we did it with the ankle certainly have helped. And again, and I fully understand that this is very early on, and then ends are very low, but we're working on getting more and more patients. Along the same lines, subtalar joint arthritis, and this was a big one for me. We see a lot of trauma. We're a level 1 trauma center, so we get a lot of these patients with the ORIFs, and then they end up with subtalar joint osteoarthritis. And we all know the problem with subtalar joint osteoarthritis is what? There's limited options. You're basically either fusing it or you're putting them in a brace. And a majority of the patients, when they hear fusion, they absolutely cringe and say, no, I don't want that, until they just can't take it anymore. So what we've been doing recently is kind of offering this as an adjunct, or a delay, if you will, in surgical intervention. So we've probably done about 4 or 5 of these, and they've done very well. I had one patient come back and request another injection because it lasted 3 months. She was pain-free for 3 months, and all of a sudden, for whatever reason, it came back pretty quickly. But we injected her, and again, she's doing fantastic. everyone's doing fantastic. Actually, I had one patient, I'll get to that in a second, that we didn't get a positive outcome, but yeah, it happens, right? Otherwise I'd be lying to you. So with subtalar joint arthritis, again, you don't need a block. We use a 21 gauge needle. So the questions I get from the patients always are, is it safe? And the answer is yes, it's safe because it's your own blood. Now there is some literature out there, you may have done your research to see that there are some case series where you can get it contaminated in there and you can end up with some sort of bacteria. It's very rare. I would say less than 1% of the time, or probably less than 0.1% of the time that would happen. But overall, it's very safe. This was a paper that looked at the safety and efficacy of interarticular injections at the ankle. They looked at pain and adverse events at 4, 12, and 24 weeks. They concluded that PRP is safe and effective in the ankle joint. The interesting thing was the kind of the apex, no pun intended, of their benefit from the injection was at 12 weeks. So patients spiked at 12 weeks. And then started to kind of come down at the 24-week mark where they wanted another injection. So obviously patients with later stage osteoarthritis did worse, and younger patients did better. There we go. The other question I get is, hey, if I do this, can I delay surgery? And so this was interesting because I get these questions all the time. So I, pull literature just to, obviously you're going to tell the patient, yeah, we can delay surgery, but is it, are people actually able to kind of show that? So this was interesting. It was 20 patients. It's not a lot of patients, but they followed these patients for 17 months. So just under 2 years. So it was 20 patients that were injected with PRP in the ankle. And only 2 of the patients required surgery. So 90% successful at postponing surgical intervention for ankle osteoarthritis. So I can safely tell patients, listen, it's not a lot of patients, but there's literature out there that shows that you can do PRP injections in the ankle and it will postpone surgery. I think that honestly, with the advent of the protein concentrate, that percentage will probably go way up, that can delay surgery or maybe even kind of postpone it forever, inevitably, if you just kind of keep on giving those injections. The other thing is, it's not like steroid, right? Steroid, you can't continually inject patients. You're going to end up with some undue harm. Here, you're just injecting growth factors. Now, it may lighten the patient's wallet a little bit, but at the same time, it's safe, and if it's effective, then let them come back and get more, until inevitably they want surgery. But a lot of times, I'm sure all of you probably know, if with the way that healthcare is these days, sometimes the surgery is more expensive than the injection. People have to pay out of pocket these days, depending on their healthcare coverage. So sometimes they much rather. I had a guy that was going to do a total ankle. He's paying out of pocket for it. I almost fell over. Anyway, so because he said it's cheaper than having health, he owns his own business. He said it's cheaper than having his own healthcare. But still, I mean, everyone's a little bit different. But again, you can tell the patients, hey, we can do this, infinity if you wanted to. And it's safe because it's your own blood. So now let's get into soft tissue. Everyone's seen plantar fascia, and the plantar fascia and PRP has the greatest, the most robust kind of collection of literature. I have a few papers here because there's so many. There's meta-analysis and all kinds of randomized control trials. But anyway, I typically will use the 5 and 2 rule, and I'll show you what that is. We kind of developed it at our institution. I'll go plantar medially. That mark is not right. That's where the patient was experiencing pain. We have some of my partners will use an ultrasound. I tend not to use an ultrasound. I'm not very good at ultrasound, to be very honest with you. So I feel like I can do it just as well using anatomic landmarks. So this is kind of,
hit the bone,
you can kind of see,
aspirate.
and then we pepper that plantar fascia there. And this is an older video, so you can kind of see how yellow that is. The platelet concentrate and protein concentrate, the PRP and the PC, it will look red. You'll see it in the newer videos. So this is a poster we did for ACFAS. So I had one of the residents locked in a room looking at 400 lateral radiographs and wouldn't let them out. But so the really interesting thing about this was, on average, the origin of the plantar fascia from posterior to anterior and from plantar to superior was about the same for every single patient, regardless of foot size, which was mind-blowing to me. And it was statistically significant. So we generated this 5 and 2 rule for injecting the fascia and for when we do our arthroscopic portal placement. But essentially, it's basically 5 centimeters from the posterior aspect of the heel. You can kind of see it here, and then 2 centimeters from the floor up, and that will give you almost every single time. Try it sometime, where the origin of the plantar fascia is. So if you have any, just a little tidbit of information there for you. So we use this all the time, and usually we'll just measure it out, and so we know exactly where we're going. And this kind of, I know you can bill for ultrasound depending on what state you're in, but this is easier for me. I kind of know the landmarks and I measure it out and do the injection. So let's dive into the papers here. So this was from not very good level of evidence to very, very good level of evidence, but this is basically just a clinical indications consensus statement from the European Society of Musculoskeletal Radiology, and they 100% agreed that ultrasound-guided PRP injections are safe and provide significant pain relief for chronic plantar fasciitis for mid to long-term follow-up compared to steroid. This was prospective study comparing efficiency and local injection of platelet-rich plasma versus methylprednisone in plantar fasciitis, 110 patients, 55 PRP, 55 methylprednisone. They measured pain, FAI, AOFAS, and ultrasound thickness, and the VAS, AOFAS, and plantar fascia thickness all improved in the PRP group, significantly more than the steroid group. There we go. So this was a systematic review. 9 randomized controlled studies identified 239 patients. PRP group had statistically significant lower scores than steroid across all time points. The interesting thing was the AOFAS scores were similar at 1 and 3 months, but as you kind of progressed on through the timeline, the PRP group did better at 6 and 12 months. Here's another systematic review and meta-analysis, 12 randomized controlled trials, 653 patients. The VAS of the PRP group was significantly lower than steroid at 6 months, 1 year, and 1.5 years. The AOFAS scores were higher in PRP, and they determined that the PRP injections were more effective than steroid. So these are all really great papers. If you want to grab them, if anyone wants to reach out to me, I'm happy to send them to you, that you can share with your patients. And you don't have to, talk the physician lingo, but you can just explain to them, and most educated patients will understand. Listen, there were 653 patients, and some got PRP and some got steroid, and the ones that got PRP did way better. And it was to the point where it's statistically significant. So do you want something that's not going to work quite as well, even though it's covered by insurance, or do you want something that's going to work much more effectively, and you may not need as many injections?
Yeah.
This was a 25-year-old graduate student with chronic tendonitis that we injected.
Starting.
And we did this in the OR.
Into the tendon. You're in the sheath. Make sure you get into
And
the
then
tendon.
you can kind of hear me talking here.
She's pretty good.
This is a long time ago when they used
In
to
the tendon.
cover. We'll kind of cover. We
Take
do
it
this
down.
prior to.
Make sure you get.
So, I'll do in most tendons. This is just the outcome of ultrasound guided platelet-rich plasma injection for chronic tendopathy. It was 180 men, women. They had all different kinds of tendons that were injected. So lateral epicondyle, Achilles, patellar tendons, PT, peroneals. 60% had 1 injection, 30% received 2, and 10% received 3. But overall, 82% had moderate to complete improvement in symptoms. So and here's where we kind of get into a gray area for me. This is a tough for me because if you read the literature on Achilles tendon injections, the question is, what are you injecting for? A majority of the literature I'm going to show you is for tendinopathy. So what is tendinopathy? So degradation of the tendon, not as much, probably late, so more chronic condition, right? So we're not talking about an insertional Achilles tendinopathy. We're talking about kind of through the mid substance. We're not talking about bursitis or tendinitis or tendinosis even. So, and you have to kind of keep in the back of your mind that the Achilles tendon has that tenuous blood supply. We all know that, especially in that watershed zone. So, and I think I told my residents this story. One of my very good friends that I golf with is a police officer, and he was a decorated New York detective around 9/11, and went on to move to Connecticut and became a state trooper. And he was very high up. He took down some very famous mafia bosses. Anyway, he moved down here and we play golf. And we were talking one time, and he got really bored and kind of depressed. And so the sheriff down here in St. Augustine, where I live, in St. Johns County, knew that he was living down here and said, "Hey, do you want to, join the force? We had a lot of young guys that could use your experience and knowledge." And so he just kind of joined part-time. And I asked him, I said, "Gary, what's the difference? How's it different? It's got to be really different, right?" And the interesting story is, and this is not to belabor the point, but essentially what he said is, in New York, if you call on the radio that you're in trouble, in 30 seconds, you have 300 cops standing next to you. If you call in St. Johns County, it takes 30 minutes to get 5 cops to you. So you better know exactly what's going on before you go into a situation. So I kind of liken that to the Achilles tendon, right? So you can put all the PRP and send all the signals you want, but if there's no one around to get those signals, then it probably is not going to work. So you have to be, just kind of careful with what you're injecting and know the literature. So of all the random, so if you look at the literature for Achilles, it's probably the worst out of any of the PRPs. So 4 randomized control trials, not criteria. This is evidence for PRP and chronic mid-substance Achilles tendinopathy. Systematic review of meta-analysis. So there was 170 patients. There was no difference in outcomes between PRP and placebo group. So they basically determined that the PRP has no clear advantage in Achilles tendinopathy. Here's another one. This one was 60 total men followed by 6 months, steroid saline and local, 4 PRP injections 14 days apart, or placebo. The steroid group did better than the PRP group. So, I'm reading these things. I'm like, I don't know if I'm bored with injecting the tendon. So is platelet plasma injection effective for chronic Achilles tendinopathy? Meta-analysis, 170 patients, 85 PRP, 85 with saline placebo, no difference in the groups. Could not recommend the use. The interesting thing is that, the question is, what PRP are they using? Are they using leukocyte rich or leukocyte poor? This might be one where you want to stimulate an inflammatory response. But then again, one never knows. But this was an animal study that was interesting to me, that they compared leukocyte rich, platelet rich plasma versus poor in Achilles tendinopathy in early stage in a rabbit model. And what they found was the leukocyte rich had much more beneficial effects than leukocyte poor when delivered at an early stage in the tendon repair cycle. So it's a matter of when you're getting the Achilles tendinopathy, and it's a matter of what formulation you're using. I also use it in kind of chronic subacute ankle sprainers. This is actually one of our APPs that I'm injecting. She had sprained her ankle like 6 months ago. We braced her. She kind of still had this kind of subacute pain. This is she's all tatted up here. So I had like one spot under her eel. She's like right there. That's where it hurts. The eye of the eel. So it was easy for me to kind of penetrate. But you can kind of see that that's leukocyte 4, but you can see how nice and red it is.
Yeah, we have to.
Do you want to watch?
She has
I'm
to.
gonna have to watch at least a step. Okay. So, you know,
And so I like to kind of pepper that ligament. And she's not liking it. But typically protected weight, I'll get into my protocols here in a second, but particularly ATF is protected weight bearing and some PT afterwards. And I try to get a little bit of subtalar joint because it was difficult to
We
assess
used
whether or not she was having a little subtalar joint pain as well. So that's why we use the leukocyte 4 rather than leukocyte rich. So anything in a joint you want to use 4, rule of thumb. Sometimes in ligaments, what you'll find is a lot of the literature shows that you sometimes do want to use leukocyte rich in the plantar fascia and in any other ligaments. So this was a study, a randomized control trial, 21 patients, first time ankle sprains, immobilized, 11 received PRP, 10 were just immobilized. The PRP group had a highest reduction in pain and highest functional scores at 8 weeks. However, it kind of tapered off at 24 weeks. But the nice thing about this is, you know, if you have an athlete that wants to kind of get back to it, you can get them back a little bit sooner with this PRP. And I think that probably the professional athletes, I know for a fact that they're getting PRPs all the time for, you know, any type of little injury that they get. I don't know why it turned out like this. It's like this new Apple thing. When I cut these images out from the X-ray and MRI. So this was a 16-year-old basketball player, high level. The basketball team won the state championship last year. So this kid's like no joke. He wants to be a doctor. Like this 16-year-old kid read about all these things, watched YouTube videos, was like, I want a PRP injection. I was like, all right, fine. So we gave him a PRP injection and he actually did really well. I mean, obviously we offloaded that sesamoid area. We got him, you know, everything under the sun to get him back. Coach needed him back as soon as possible. He was back playing in 2 months. So we've had a lot of great results. My partner does a lot of plantar plate, which is interesting, plantar plate injections. So patients that come in that don't necessarily want to do a plantar plate, and anyone that's done a plantar plate repair, I don't do them. I send in my partner because he's very good at them. To me, it's you have to do a lot of them to be, you know, to kind of be effective. And he's very effective. So I have no ego. I'll send him to him all the time. But he does a lot of plantar plate injections, and we're coming out with a paper. He's coming out with a paper for PRP. Now he's a little bit different he's a lot more protective when it comes to weight bearing. So he does not let them weight bear for 3 weeks. But he finds it's a great alternative surgery. He's gotten really good results. And I know I keep saying that, but you know, you just have to kind of trust that I'm telling you the truth, but I don't know why I would lie. But anyway, you know, he harps on it. He was the one that told me to do it. So he puts them in a boot, has them weight bearing at 3 weeks. He'll do multiple plates. He'll always get an MRI just to verify that it's not, you know, beyond kind of a grade 2. So, you know, partial tears he finds works best. So here's just kind of a case series I threw in here of 3 athletes, and a 220-year-old and a 19-year-old. The dancer was a 20-year-old, the runner was a 20-year-old, and the squash player was a 19-year-old. They had successfully treated with PRP injection for sesamoid fracture, and they were back to athletic competition within 2 months. So you know, it's a very effective, especially the newer PRPs are very effective in treating, I think, in treating sesamoid fracture. And those of you that know how difficult it is to treat a sesamoid fracture know that this is a great alternative to that. You know, you don't have a whole lot of options when it comes to sesamoids. You're either taking them out, you're doing a bone stem, or in my hands, we're doing a PRP injection or PRP plus a bone stim. So these are my protocols. Essentially, you want patients to have stopped any anti-inflammatory at least 3 days prior to. I ask them to do a week before the injection, if you can help it. And then they have to be off of any type of anti-inflammatories for 2 weeks. Because if you think about what's happening, you're trying to kind of trigger that cascade, and the anti-inflammatory actually blocks that cascade. So we absolutely don't want that to happen. Otherwise, you just basically undid everything that they just paid for. So I have a sheet and I have it in big bold print. Do not take any anti-inflammatories. These are anti-inflammatories, and like list them out. They can take Tylenol. Most of them are placed in a short cam walker, depending on what's done. If it's a kind of a peroneal tendon or posterior tibial tendon, I'll tend to put them in a taller cam walker, or even Achilles tendon, although I kind of moved away from Achilles tendon. And I essentially asked them to be non-weight bearing for the first 24 hours, rest and ice, and then I have them weight bearing in the boot for 1 to 2 weeks, and then slow kind of wean out of it. Now, depending on what the procedure is, will depend on whether or not I prescribe physical therapy. And it depends on the patient, really. So if you have someone that comes in and you know that they're not going to do the home exercise program that you prescribe to them, then certainly send them to physical therapy. If it's a little bit more complex of a problem, I will also send them to physical therapy. So you definitely want to offload sesamoids. So I'm going to say offloading as necessary after the boot. So typically, if you have a sesamoid, find the root of the problem. If you solve the inflammatory problem, but you don't solve the underlying biomechanical problem, they're just going to have that problem come back. So obviously, you want to address those things as well. So, cutouts for first, for the sesamoid, orthotics as needed for plantar fascia. Everyone has their own algorithms, and you can use your own, whatever that is. So you're never too young. You're never too young to learn. So here's some stem cells, and not only am I a user of Apex, but I'm also a patient. This is my partner injecting my shoulder. I had a slap tear. So not only do I see it work in the patients that I treat, but I am also a patient that has been treated by this product. So I had PC and leukocyte injected into my shoulder and around my shoulder, had a slap tear. I had a very big golf tournament coming up. I requested that my partner inject me. So he's kind of a funny guy. He's a Army. He was at West Point. I don't know. I'm not a very big person, but he's a very big person. He played linebacker for Army. And he's just, a funny kind of guy. He's, yeah, we'll blast about 8 billion platelets in your shoulder and you'll be fine. It's like, great. He said, either that or I'm scoping it. And I said, no, you're not scoping it. So we landed on 8 billion platelets in my arm, or in my shoulder rather. And I have to be honest with you. So it was sore the first day. The second day, I noticed about 50% improvement in pain. Anytime I kind of reached over my head, it was giving me some discomfort. I laid off the golf for about a week. But over the course of 5 days, I have to be honest with you, I had probably about 80% improvement in pain, and I could golf without any pain, which was perfect because it was perfect timing for my tournament. Unfortunately, we didn't win, but we played well. But in my opinion, it's an interesting product, especially the protein concentrate. I think there's a time and a place to use it. I think there's a time and a place to use it in your practice. Certainly, we've implemented it in our practice. And like I said, I think the protein concentrate piece of things is a game changer because you can offer it to the patient in lieu of surgery right now for an arthritic condition that they're probably going to need a surgery down the road at some point. But you know, a lot of patients, again, A, can't afford surgery, B, don't want to have surgery. And this is the landing zone for those patients, is right in this zone. And, you know, a lot of them will do it. I've had, like I said, I've had probably 4 or 5 that did a series of injections and just keep on wanting it. They don't want the surgery. The one failure I did have was interesting. I had a guy that had plantar fasciitis chronic for like, I think he said like 6 or 7 years. And it's like, you know, the patient exactly what I'm talking about, who's come in extraordinarily nice, had been to 3 other doctors. They had done everything that you would have done. And you're like, all right, well, did they do PRP? And they're like, yeah, he did this. And you look it up and it's not quite the same. But he's like, I'm willing to try this different PRP. So the problem with this guy was he's super active. He was a pilot. He wants to fly. He's got the pedals in the plane, so he's constantly using them. And it hurts him when he moves up and down, the ankle up and down, especially around the perineals. So, you know, he said he got about 3 days relief and then it came right back. And then his wife's with him and ratted him out, and she's like, "You weren't wearing the boot." And I was like, "Okay, well, that could have been it." So we sent him to physical therapy and still waiting to hear back about how he did. But we have about 8 minutes left. I'm happy to take any questions. I'll stop sharing here. There we go.
Okay, Dr. Piraino, we've got a handful of questions that are coming in.
Okay.
So one was, I currently use PRP. When do I add protein concentrate? I know you just kind of touched on that towards the end. That came a little earlier, but
Yeah, that's a great question. And so usually I'll add protein concentrate in patients that have kind of recalcitrant problems. So if you used PRP before and you just kind of noticed the problem came back, adding those additional anti-inflammatory properties sometimes help with the pain, even in the soft tissue. Like it worked for my shoulder. We used protein concentrate, and I mean, it was in the joint. But always, I always put protein concentrate on any joint that I do. So, for instance, my colleague who's the neonatologist who's had the OCL, he did all the literature research, and we injected the protein concentrate in leukocyte poor. So you want leukocyte poor and protein concentrate in almost all joints. You almost never want to use the leukocyte rich in a joint because you don't want that kind of inflammatory cascade happening inside the joint. But that's typically when I'll kind of bring out the protein concentrate with patients that are either difficult or a spot that, you know, you're kind of on the fence about, like the ATF. You know, you're near the subtalar joint, so I'll use protein concentrate in there just because sometimes if you kind of go through it leaks in. And sometimes, hey, it could be a you know, a little bit of subtalar joint arthritis you're not seeing. So
great. And then we have another one that's stated, in your experience, how long do patients typically see benefits from a PRP injection?
yeah, so again, that's a great question. It really depends. It's A, patient dependent, B, procedure dependent. So one of the things that I do want you to take away from this discussion, though, is that not only are not all PRPs the same, but every patient is very unique. And so the older you are, and depending on your blood levels and your counts and your health, will determine how much growth factor you actually have. So I would say on average, 6 months benefit. Most of the time, you know, I have depending on so for joints, I'll break it down into procedure. So for joints, 3 to 6 months. For plantar fascia, probably more like 8 months, sometimes a year. That I'll help people come in for an annual PRP injection for their plantar fasciitis, especially if it's recalcitrant. For tendons, I kind of backed away from the Achilles, but for peroneal PT tendons, 3 months, I mean, is a good number. On average, I would find that, you know, patients get benefit. So it's a very good question. So sometimes, you know, when they come in, I tell them, listen, it could last a week, it could not work. it could last a year. Everyone's a little bit different, but on average, if we're injecting your PT tendon, depending on how bad your tendinopathy is, 3 months to 6 months. You may need another injection. Again, it's relatively safe to do these injections. It's not like a steroid where you can't inject a tendon. You could, but you have to protect them. But you can inject these tendons in the sheath or in the tendon itself, and it kind of helps. And even the Achilles tendon, a lot of the literature talks about kind of dry needling, and our therapists will do that as well. So not only is it safe, but it's effective. So.
Great, thank you. We have a few more we'll try and get in time. So one was actually a question about the block. So it said you talked about a block for hallux limitus. Do you do a Mayo block or just a local at the site?
Usually do a Mayo block, just because I did a local at the site and it got a little bit painful for them because it was so much fluid. It kind of leached distally. So I usually just kind of do like a Mayo block. It's a little bit less painful for the patient. The further distally you go, the more painful it gets, and there's more volume in there. And so I try to maximize the amount of volume I can get in the first met. And so even just kind of a local block sometimes can leach near or around that area. And you have to be careful with, the vascular issues and things like that. So.
Okay, thank you. This next one says, for a PRP injection for plantar fasciitis, approximately how long before the relief kicks in?
How long before the relief kicks in?
Yeah.
I've had patients have, within 24 hours, call me and say, I'm doing great. I've also had patients, it takes up to a week. So I'm sure that probably that person has given a PRP injection and their patient's probably like, hey, I haven't gotten relief. What's going on? So it depends on the chronicity of the plantar fasciitis, and the ones that are more chronic tend to take a little bit longer. And so those patients, honestly, I'll kind of non-weight bear a little bit longer than the 1 day. I'll go out probably like 4 or 5 days and ask them to stay off of it for a while. And I think that's where the patient that I had that failure where we went wrong was I didn't emphasize to him that he needed to stay off of it because he was such an active guy and just kind of went right to it. So you got to give the body a chance to respond. And so, patients that have kind of more subacute, early chronic plantar fasciitis, less recalcitrant, they'll probably be fine within 24 hours. But the ones that have been dealing with it for years, I would give them at least a week and not weight bear them for that long too.
This next one is, if patients need to avoid NSAIDs, do they require post-injection pain treatment? If so, what do you recommend?
Usually I recommend Tylenol, to be honest with you. We don't use opioids at all. So, usually Tylenol and a little bit of rest and ice and elevation. And so that patient I was telling you about, she like went diaphoretic on us, like had pain, significant pain in that hallux she sat in the office for like an hour because she was like, I am not leaving until the pain goes away. So we actually tried like an ankle block and she still had some discomfort. You can do, if they're having that much discomfort, you can do a rescue block on them. But typically, from a medication standpoint, I mean, I'll just do Tylenol, tell them to take some Tylenol and, kind of cycle that. But other than that, that's basically what we offer.
Okay, looks like we have about time for maybe one more. And this one's more on dosage. So it asks if you know, or in your experience, what's the minimum number of platelets needed to see a clinical benefit?
I honestly, that's a tough question because it depends on what you're injecting, right? So if you have, using a different company and you're using a certain percentage, I would say, you want upwards of 1 billion platelets to get some sort of clinical, response. And I think that was, sometimes, we look back and look at the science of, PRP's been around for 15, almost 20 years now. And it's only improved. And what we found was that it depends on the number of platelets. And in my opinion, I think you got to have over 1 billion to get some sort of clinical response. But the more you have, the better off it is, because the more you have, the more growth factors you have, the more response you have, the more cells will get recruited. So I'd say minimum, the cutoff number for me is like at least 1 to 2.
Okay, perfect. Well, Dr. Piraino, thank you so much for your time. We really appreciate it. Again, we're essentially just getting started. So, ladies and gentlemen out there, we'll be taking a short break between webinar sessions. If you plan to stay with us, use this time to stretch and recharge. We'll let Dr. Piraino go grab a drink if he needs, and we'll resume shortly. So be ready with some more more questions, and we hope to continue on with this engaging discussion. We'll see you all shortly in a few moments. Okay, we'll go ahead and get started on this second session. So welcome back to those of you who joined us for the first half, and welcome to those just joining us for the second half. This is our 2-part webinar series with Apex Biologics featuring Dr. Jason A Piraino. We will now dive into the advanced foot and ankle biologics, revolutionizing the biology of autologous biologics. So again, for those of you that are just joining us, it is our honor to again introduce our colleague, Dr. Jason A Piraino, DPM, MS, FACFAS, who is an associate professor and chief of the Division of Foot and Ankle Surgery at University of Florida College of Medicine, Department of Orthopedic Surgery and Rehabilitation in Jacksonville, Florida. He also serves as the residency director for the University of Florida College of Medicine, Jacksonville, Podiatric Surgery and Medicine Residency. He has received multiple awards for excellence in teaching at the University of Florida College of Medicine, Jacksonville. He was recently appointed to the American College of Foot and Ankle Surgeons Board of Directors. He also has a unique perspective in product approvals, as he has served as chair of the Value Analysis Committee at UF for the last 10 years. Without further ado, let's welcome Dr. Jason A Piraino to share his valuable insights with us. I'll pass the time over to you, Dr. Piraino.
Thanks again. And those of you that have dared to stay on for the second session, you can just mute me for the first like 10 minutes because they're identical slides. So I just wanted to make sure anyone that came in had heard the science behind it and what Apex has to offer. So if you want to take a 10 to 15 minute break, go for it, because you're not going to miss anything for the next 10 minutes. Also, it's being recorded, so if you request the version of it, we can do that as well. So I'm going to go ahead and share my screen here. All right. So we'll get started here. So we're going to talk a little bit about the first session. For those of you that weren't here, we discussed kind of the outpatient, kind of in-office basics of PRP. This session's dedicated more to the operative use of PRP and other products that Apex has. One of the products I didn't touch on is BMAC in the previous lecture, which I will talk about in this lecture. But again, I had basically what I had said in the previous is this slide right here is the most important thing. So this is what I want you to learn from the webinar, or hopefully take home from the webinar. So the science of healing. So we all understand the science. So it's just a short refresher course on how we heal, whether it's a bone, a joint, a ligament, a tendon, a wound. How do we heal? And so hopefully everyone kind of gets that refresher course and has that in the back of their mind. And then we'll talk about the products that Apex has to offer. So not just PRP, but there's other really, really interesting products they have that we'll talk about and why it's different. And then the majority of the talk is going to be about when, what, and where should we use it in the OR. And then some literature kind of intertwined among all the slides. This lecture will probably be a little bit quicker than the last lecture, although we do use the PRP and BMAC a lot in the OR. it's funny when I was putting this lecture together, I was talking to the residents, like, I mean, usually when you're taking pictures of, you're doing flat foot reconstruction, you're doing an Evans, or you're doing like even a bunion, and you're like, oh, look at this, and you take a picture of that. When we use PRP, it's usually not, you're not taking pictures and there's nothing exciting about it. So there's not a lot of visual learning going on, unfortunately. So everyone's a little bit different. I'm more of a visual learner, so I like to put pictures in. And so I was struggling with like trying to find pictures to put in here. So I try to give procedural knowledge, like what I'm using it for, at what point do we put it in there, how we're using it, and then, why we're using it. So again, here we go. And again, I told you that they're going to be exactly the same slides for the next 10 slides. So those of you that were on the first session, just either put your earplugs in or just la 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 for a little while. So we have the 4 phases of healing, whether it's bone, soft tissue. There's a coagulation, inflammatory, migratory, and remodeling phase. The first 2 phases involve platelets, where you get recruitment of the bigger cells and the other cells. And then that kind of kicks everything into the migratory proliferatory phase. There we go. So PRP, just basic PRP. So anyone can say they have PRP if they have basically concentration of platelets over serum baseline. So you have to be careful what you're using. Not that back in the day, this PRP has been around for close to 20 years. People were even injecting whole blood at some points, and they were studying whether or not whole blood was better than PRP. But every system's a little bit different in the percentage of platelets recovered, how much, what leukocytes there are, whether or not those of you that were, been doing this for a while know that early on you had to activate, the thought was you had to activate the PRP with thrombin, and that was just the wrong thing to do, because then basically it released everything all at once, and then if you don't do it at the right time, then you miss out on all the growth factors. And then, fibrin formation. Some products out there kind of spin down even further and get kind of a fibrin glue or goo, if you will. So this is what the PRP looks like from Apex's standpoint. It's a little bit different. Theirs is kind of inverted, which is nice. So with PRP, you have the plasma layer, you have the buffy coat, which contains the white blood cells, and then you have the red blood cells. And kind of every layer overlaps the other one. The buffy coat is really, really important because that contains your white blood cells, your mononuclear leukocytes, and your multinucleated leukocytes, whether or not you want pro-inflammatory or non-inflammatory cells. So leukocyte poor versus leukocyte rich. And then you have the platelet poor plasma at the top here. So when they designed this bench top centrifuge apparatus, they really did a nice job of kind of keeping the physician patient in mind. So it's very flexible system. So you can when my rep comes in, it's like, hey, what do you want? Leukocyte rich, leukocyte poor? Do you want protein concentrate? Do you want this? Do you want that? You have a lot of options, which is fantastic because every single patient's a little bit different. And so you can tailor your treatment to your patient based on what you want to get out of the PRP. So again, you can kind of see what they're doing here. They're lifting the PPP off, and that kind of allows you to pull off the buffy coat nice and easy without disrupting the PRP. Other platelet systems sometimes make it very difficult, and sometimes you end up with too many RBCs in your PRP, which can become detrimental sometimes. So this one was big for me. And again, I keep reiterating it. Those of you that were listening before, I'm sorry, but this was huge for me. This is one of the reasons why I switched from the other company I was using to Apex, because I'm a firm believer in this protein concentrate. The technology they have, their PRPs more potent, and the fact that they have this protein concentrate was the game changer for me. So essentially, historically, we all know that platelet poor plasma, I used to take it and just inject it up over the incision. It would help kind of as a closure device or to help close the wound. The interesting thing about platelet poor plasma is that it contains a lot of things that we don't realize. So it's got something called A2M, IRAP, some cytokines and VEGF. And so what Apex has done is they've developed this filter, which I'll show you in here in a second, that removes about 75% of the water and concentrates these proteins. So A2M is the big protein. It can't readily migrate across into the synovial fluid because it's a huge molecule. It's very big. So it can't get across. But what it does is it lures catabolic enzymes and active proteases into the joint. It's irreversible. So it just kind of pulls all the bad stuff out, essentially. It's like a filter. It catabolizes enzymes that break down the joint, and it mitigates the effect of these enzymes. So basically, you can potentially slow the degradation of cartilage breakdown and progression of osteoarthritis by using protein concentrate. IRAP also is a molecule that's in there. The interesting thing about PPP is initially people had studied, if you read the literature, IRAP for a while, and they found that it was kind of inconclusive, that it didn't really do a whole lot on its own. But what we're finding is the combination of A2M and IRAP together with concentrated like this really does a nice job of kind of slowing that progression. There's clinical trials underway. We're working with Apex to kind of see what's happening in the foot and ankle as it relates to using the protein concentrate and the PRP. IRAP binds IL-1 receptors if anyone's interested, and prevents IL-1 from producing pain and inflammation. So it reduces pain and inflammation, and the A2M pulls those degradative enzymes out. So here's the filter. This is our rep. And it's kind of really neat because what it does is you can kind of see it's got a 15 kDa filter pore size, so it kind of filters everything out, and it leaves the A2M and the IRAP in there.
Yeah, isn't that cool?
And you'll see the
A lot of
water
foam
kind of come
too,
out of
where you get,
that.
like, super
So that's the
concentration.
PPP, and you end up with this kind of super concentrated platelet poor plasma that's basically a protein concentrate.
You'll still have more than you need.
And you'll hear it say
For
here,
what
it looks
you're
like
doing,
vodka,
but-
which it kind of does. But super clean and really an interesting process. So when it comes to PRP, numbers really matter. So essentially what we're looking at is platelet recovery, platelets out divided by the whole blood platelets in. It lets you know how efficiently your device performs compared to another. Platelet enrichment is platelet count concentration in PRP divided by platelet count of the blood. Enrichment tells you how much better their PRP is compared to blood for any given PRP volume. Having 3 milliliters of 10x PRP is not better than having 6 mLs of 6x PRP. In order to do an apples to apples comparison, you have to consider the volume and platelet count of the input blood platelets in, basically, and the volume and platelet count of the PRP out, platelets out. So we want to see the percent recovery and what are we getting. So PRP volume should be the max that the physician is comfortable using. So usually what we get, you're drawing 30 to 60 cc's of blood, and you're ending up with 7 cc's, which we never ever have to use in the lower extremity. So we always have some to waste, or I never really waste it. I just offer the patients, hey, do you want to try a different joint? So you can also add more of the protein concentrate in, so you can combine these things. So with protein concentrate and PRPs, you make these super constructs. So one of the things I didn't talk about in the last lecture was BMAC, bone marrow concentrate, essentially. The reason why I didn't really talk about it in the outpatient setting is you can do this in the outpatient setting. I know there are orthopedic groups in the area that do it. It's just that if I'm a patient, I'm not necessarily on board with someone sticking, an 11 gauge needle in my hip to draw blood while I'm awake, or platelets while I'm awake, unless I'm really desperate, and having to pay like $4,000 for it at the same time. So, yeah, so it's like, you're kicking me while I'm down, or taking my money and, making my hip super sore. It's not the most fun idea for me if I'm a patient. But anyway, if you're under anesthesia, it's a different story. So I've kind of included it in this lecture for that reason. The thing about BMAC is it contains the cells. So mesenchymal stem cells, so it's your stem cell, hematopoietic stem cells, endothelial progenitor cells, sorry, white blood cells and platelets. So the difference, basically it's like PRP on steroids. PRP plus is what I call it when patients ask. You can just tell them it's stem cell therapy. You have to be careful with that that verbiage though, because it kind of gets sticky sometimes. It contains similar to what PRP has. It's got the growth factors, but it also has the cells. So it has everything you need to heal what you want to heal. So Apex has their BMAC kit, the BMC. And so usually we'll draw about 60 cc's of bone marrow. I'll either take it from the distal tibia, I'll have one of my partners pull it from the hip. And we'll get, they get a good recovery. So 84% of total nucleated cells from the bone marrow harvest, you usually get a really good recovery from this. It's similar kind of desktop kind of press here. It's designed to maximize total nucleated cells, and usually end up around 9 to 10 cc's. And so their systems, plural, are not only affordable, but they're flexible. So you have a variety of things you can use with. So you have, not only do you have PRP and BMAC, but you also have protein concentrate. So you throw that added third kind of product in here, and it makes that's the primary reason why I switched to using Apex, was because of the variety of things I can do with it. I have the ability to, get stem cells, and if I want to inject a joint with it, it's even better. If I have a osteochondral defect, we'll talk about that in a second. You can do that. So it's not only affordable, flexible, and efficient, but it's simple. They have this desktop press that nurses can use. It's super easy. You don't have to worry about kind of skewering or messing up the pull. It's really easy to use. I've done it before in a pinch. So if you can't, you don't have a rep around and you need to do it yourself, or your staff needs to do it, it's very easy to use. So let's talk about operative treatment in the foot and ankle using biologics. So indications. So bone and joint procedures, we'll start with that. I mean, really, you could use it anywhere in the OR, in my opinion. I just kind of listed a few different areas that I think are apropos. So chilectomy, we talked a little bit about hallux limitus in the first lecture and using it in patients that didn't want surgery, but you can also use it in patients that do need surgery. So chilectomy, I use it in all my total ankle replacements. Any arthrodesis, I'm using BMAC, bunionectomies, and then your soft tissue, Achilles, ATF, tendon scopes, ankle scopes, you name it, we use it. Actually, I was going to put a screenshot of my residents. We have a group chat in our residents, and one of my residents just jokingly sent me the picture of the flyer of me on there, and one of the other chief residents jokingly put in the Frank's Red Hot. I put that shit on everything and said, pretty much Dr. P. So they kind of know me ever too well. So on my case cards, I typically always have like BMAC and PRP, depending on what the case is, honestly, but I always like to have them there if I need them. There we go. So hallux limitus is similar to this last slide we saw. We're not talking about rigidus. Obviously, we don't want it deal with somebody that's going to need a fusion, although you can use it in patients that need a fusion because you can use the BMAC to help heal that fusion a little bit more effectively. But in the chilectomy, I'm usually pretty aggressive with my chilectomy, like an aggressive Valenti. And for a while, everyone knows there was that Jujube implant that was replacing the cartilage, and that turned out to be a disaster. People will microfracture. You can try allograft if you need to, if there's a big defect. There's other products on the market that you can use. But what I've been doing recently, and I've probably done it in the last, I looked back on the last 4 chilectomies that I'd done. I used this protein concentrate in PRP. And early on, early indications are that patients are doing better and have less swelling, less pain, and actually are getting out of the boot into a sneaker very quickly. Like I said, I usually put these patients in boots, let them walk waper right away. I just had, actually was in the office yesterday. I had a post-op patient come in, and it's been 3 months, and I just asked her to talk me through how she did, and she said she had almost no pain initially. She had some swelling. It reduced, and she was walking in a sneaker in 2 weeks, even though I didn't want her to do that. But she's like, hey, I'm walking in a sneaker, no problems. I'm not having any pain. This is great. I want the other one done. And yes, is the chilectomy effective on its own? Sure. But the fact that we can add the protein concentrate in and potentially reduce the need for, necessitate the need for a fusion in the future makes it all the better, in my opinion. So if I can prolong the life of the chilectomy, which on average is between 5 and 10 years, depending on what stage you're in hallux limitus. And if I can make that 5 years, 10 years, or make that 10 years, 15 years, that's fantastic. I'll do it. And so the patients are all on board with it. They understand. I explain everything to them ahead of time before we go into the operating room. We're going to do this and why we're going to do it. And, there's not a lot of literature to suggest it. This was interesting because this was 45 patients that they just used a PRP with a resorbable implant. They saw significant improvements in AOFAS scores over 2 years and found that it was safe. And they had notable improvements in pain and function over 2 years with the use of PRP and this polymer-based implant. That was kind of like looks like a little strip you kind of put into the joint. But that was pretty interesting. It was really the only literature I could find on use in hallux limitus. Ankle joint replacement. So anyone that does ankle joint replacement knows that there's historically a 20% dehiscence rate because of the incision placement is between 2 angiosomes, and it's a tenuous area to begin with. And if you're not, doing these procedures relatively quickly and you're having your retractors held like this for a long period of time, it leads to dehiscence. And so we do everything possible to prevent that from happening. So for every single one of my total ankle joint replacements, I always use PRP. It helps promote angiogenesis, especially at the incision site. So this is just kind of the PRP. You can kind of see here post-operatively, the incision's closed. Given that injection. This is my scrub tech who does the PRP dance whenever this is the PRP.
Yes.
And I'll try to join them. Unfortunately, you have to see that. But you can see him going to reach for the PRP there. So in every case, he does the PRP dance because that means it's the end of the case. So we always do the PRP dance in the total ankle. Moving on to kind of arthrodesis procedures. Sorry, I'm trying to move this thing. In my opinion, any arthrodesis that you're doing, any fusion, could always use a little help, especially in the areas that notoriously are difficult to heal. And that goes for fractures too. So anything that, in the past that, you have had issues with, medial doubles, we're getting the TN joint or the subtalar joint to heal, historically a 10% non-union rate. Lapidus sometimes, depends on what you're doing. Using BMAC and PRP inevitably will help. those sites to heal. The nice thing about it is you can use the BMAC with an allograft and almost make an autograft essentially. We use a really wonderful allograft that's from younger donors and mix it with the BMAC and use it for most of our arthrodesis. I think I have, there we go. This is a case of mine, a 48-year-old male in a motorcycle accident in Ghana 2 months ago. And they just let it sit like this. Anyone that knows ankles knows that that shouldn't have sat like that for that long. So we had a long, hard discussion with this gentleman who was in a significant amount of pain for obvious reasons for 2 months until he got back to the States. You know, what the best option for him was. And, you know, we discussed either we fuse his ankle or we try to, you know, do something heroic and, you know, RIF him. But at this point, it's kind of the damage is done. So he opted for the fusion. So we did an arthroscopic ankle fusion. This is one of the grafts we use called OsseGraft. We mixed it with BMAC, and you can kind of see here a little slurry. Pack it into that site. And within 3.5 weeks, we had, you can kind of see the bone kind of leaching out there, but we had a pretty solid union. I'm getting CT scans to verify that. But the one thing, and I tell my residents, listen, we treat patients on an x-ray. So the guy walked in 3 weeks, no pain. So granted, he wasn't walking, but he had a dislocated ankle for 2 months. But that being said, I mean, the guy was like thrilled. I was like, why are you walking? He's like, I can walk. It doesn't hurt. I was like, okay, well, good for you. But you know, these are, again, isolated cases. I can't say that it's going to work for everyone the same. And that every patient that has an ankle arthrodesis is going to be pain-free at 3 weeks or have a fusion at, you know, 3.5 to 4 weeks. But, you know, this is just one case that, you know, we saw that we had done something a little bit different. So I also have been using it in most of my bunionectomies, and this is why, and I know it's kind of probably overkill, PRP at least. So I started doing the minimally invasive surgery, the little burr cut osteotomy, the chevron on the mica, and was getting pretty good results. The issue was what I was finding was, and I'm sure people that do it maybe see the same thing, is when you cut that bone and you're not doing an open procedure, there's nowhere for the bleeding to go. So you end up kind of getting a small hematoma in that area. And you can mitigate that however you want. But they, you know, inevitably would get swelling because you're telling them you can walk on it and blah, 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 blah. And so I limited that. And so I had them not weight bearing for a week. And then they still would get swelling right around 4 weeks. So I said, well, why don't we try doing PRP and see if, you know, with the protein concentrate and see if that helps because it's supposed to help reduce inflammation and pain. So we started doing it with the protein concentrate, PRP with the protein concentrate in bunions. And I got to tell you, it was like night and day for those patients that we were seeing post-operatively. I had one patient, she's 54. She's an avid tennis player. So she came into me last Wednesday and she's like, hey, she's 6 weeks. And she's like, hey, I got a little bit of swelling. And I was like, oh. And she's like, but I was fine before. And I was like, well, what were you doing? She was like, I did a 90-minute, like, high intense tennis thing. And I was like, what? And she's telling me that she's doing this like 90-minute, like, she teaches tennis, apparently, tennis camp. And I was like, what were you doing? And she's like, I was running around. She's like, I also do yoga. I had a hard time kind of doing the certain poses because I can't get my toe to dorsiflex. I was like, well, yeah, because it's swollen. And probably because you were just doing the 90-minute, you know, super tennis camp. So it's just things you start to see subjectively. And so we're trying to collect data on these. And, you know, I think inevitably, so the top picture is 1 week post-op. The bottom picture is 4 weeks post-op. I think the incisions heal a little bit nicer as well. So, we're seeing really good results with the use of the PRP and the protein concentrate when used with bunionectomies. And some people may say it's overkill, but you know what? If the patients are happier and they're getting better faster, to me, it's not overkill. So the only reason I put this in here was because of this paper. So, anytime I research anything, I kind of research everywhere. And so this paper came up, and one of my partners who's sports medicine kind of was like, hey, you should check this out. Because I was telling him I was doing a lecture. And I had done a lecture before, and I had read this paper. If you read this paper, it's incredible. So, to me at least. So they had 45 patients that received BMAC injection during rotator cuff repair. They had 45 patients that only had the rotator cuff repair. Talk about follow-up. So the BMAC group had enhanced healing rate, improved quality of repair based on ultrasound and MRI. They did ultrasounds and MRI. 100% of the BMAC group healed by 6 months versus 67% without. I mean, if you're an orthopedic surgeon that does sports medicine and does any type of rotator cuff repair, damn it, you better be using BMAC. And if I ever need a rotator cuff repair, I am getting BMAC. The really interesting thing was they follow these people 10 years out. So not only did they do 100% better or 50% better than the non-BMAC group, but they also, after 10 years, 80% survivorship in the BMAC group versus 44% in the non-injected group. So 50%, more than 50% are not, their rotator cuff repairs after 10 years aren't holding versus 87 if you use BMAC. So the reason why I put this in here is because I think that using BMAC in the O or even for soft tissue has a role. So Achilles, and that's what brings me to this slide. And anyone that was on the previous lecture, you heard me talk about the literature and how poor it is for Achilles tendon. And it's equally poor for Achilles tendon, PRP and Achilles tendon repairs. So I used to just do it until we started I was researching things, and I kind of limited myself to the Achilles tendon injections in the clinic because of what the literature shows. It's not very effective. But the interesting thing is, if you read the literature, there's not a ton of literature on using BMAC in Achilles tendon, but we started using it for our repairs. And for anyone that has kind of this Achilles tendinopathy, we'll do like a gastroc lengthening and do the injection. We started getting good results. And you'll see that there's only a handful of papers that do it. But even kind of at the Haglund's, when we do Haglund's repairs, we use this. So the Achilles tendon is percutaneous. We use BMAC. We have to, the problem with getting for the BMAC for Achilles is that you're prone. So usually we have to get it from the calcaneus. So, you're not getting as much volume from the calcaneus as you could from the proximal tibia or the hip. Even in the hip, it's difficult when they're prone like that. So this was outcomes of acute Achilles tendon rupture repair with bone marrow aspirate, 28 ruptured tendons treated with open repair and BMAC. Excellent results. 0 re-ruptures out of the boot in less than 2 months, and 92% of the patients returned to sport. So my protocol for Achilles, if anyone's interested, I actually weight bear these patients immediately in a protected boot, obviously with a wedge, and have them moving at day 1. It's important. You should absolutely mobilize these patients. Do not immobilize these patients after an Achilles tendon repair. You want Wolff's Law working for you, not against you. Find a good therapist because when you let them sit, you end up with scarring, and that leads to re-rupture. So you want the collagen to lay down in parallel. You want elasticity. You do not want that scar tissue. So moving on to arthroscopy, tendoscopy. So I included arthroscopy because typically it depends on what we're doing procedure-wise, but anyone that has usually an osteochondral defect, I stopped doing microfractures, started kind of doing the if there's a subchondral lesion, kind of retrograde drilling and then backfilling that, and then if there's a cartilage lesion, kind of using the synthetic cartilage. But what we're doing now is mixing the BMAC with the synthetic cartilage, getting some pretty good results. And that's where kind of the arthroscopic aspect of that ends. If you have a patient, if we do have a patient that you detect osteoarthritis, you will put protein concentrate in. That's why I have the rep bring the kits all the time into all the cases, just in case, because you never know. Because if you can, that patient can benefit. So what we'll do is we'll scope them if they have something in there. Even after we do the BMAC, we'll inject them at the end. We'll evacuate the joint, inject with some protein concentrate, platelet or leukocyte pore plasma. Going to throw the whole kitchen sink at them. When we do I do a fair amount of tendoscopy. When we do tendon scoping, we will use leukocyte pore PRP. We'll debride the tendons, and then what we'll do is you can actually visualize I was trying to find the video of the needle kind of going into the tendon. You can watch the needle penetrate the tendon and inject. It's kind of neat because you kind of see that tendon fill. And then what I'll do is I'll take the, let's see if I have a picture. I don't have a picture of it. So this is PT tendon scoping. This is PT tendon on the left. This is me kind of doing it. So we'll do is that port right there. I'll lure lock the PRP on that and put it right into the sheath, as well as kind of inject it into the tendon when we're done. After you gotta kind of evacuate it. And so this is what the PT tendon looks like under arthroscopy or tendoscopy. And kind of see, sometimes you'll see some inflammation. We'll get there in the, this is a PT tendon repair open for a flat foot we did the other day. You can see how terrible that is. We cleaned that up and did a nice PRP injection here. You kind of see the tendon kind of inflating. Give me 5 more minutes. I need 5 more minutes. That was the end of the case. So perineal tendon scopes, similar to PT tendon scopes. You can kind of see here the incisions. And you can kind of see that tenosynovitis there, the inflammatory little flap as we move the tendon. This is a good, patients like this in lieu of an open procedure. If you can kind of do that with the PRP, that's one of the ways I tell them that you can kind of get the PRP. It's a cheat code basically for PRP. So if you want a PRP, we can do like a minimally invasive procedure and just put the camera in and see if there's anything torn and be the equivalent of doing an MRI, or you could just pay out of pocket and do it in the office. But usually what we'll do is we'll do this. You can basically, if anyone's interested, the code for that is tenolysis. So you do a tenolysis, you put a little camera in, you kind of debride out the tendon, and then you inject the PRP. So you'll see here, there's the perineal tendon, that's brevis, and I think we'll see longus come in here in a second. Come on, longus, where are you? Don't hide. There we go, we kind of flip between them. It takes a second. There it is. It's kind of off to the right there. We kind of flip around them. Anyway, so I will do that for almost all of the tendon scopes. ATF repairs, I usually do mine all inside arthroscopic. Sometimes if there's one that's chronic, that's really chronic, that has had previous treatment, I'll use a graft. Sometimes we'll take that graft and soak it in either BMAC or PRP. And if we're just doing it all inside, I'll evacuate the joint and inject like I did in you guys didn't, unfortunately, of those of you that jumped on later, I did a PRP injection into one of my APPs in her ATF. She's got a chronic ATF tear. And I'll just kind of pepper that area when I'm done. So future considerations, I told you I was going to be done early. Using intraoperatively post ankle calcaneus talus fractures because the degradative enzymes are present at the time of fracture. And so if we can stave off those enzymes using protein concentrate, I think that we have in a possible wonderful potential to prevent osteoarthritis from occurring rather. So those of you that know, the cartilage in the talus is very different than the cartilage anywhere else in your body. It is designed to withstand multiple beatings. The amount of body weight that kind of is transmitted through the talus cartilage is incredible. It's 10 times that in the knee and 20 or 15 times that the hip. But essentially it's kind of dense and compact and can take a beating. And most patients don't, if you think about it, most patients don't get primary osteoarthritis of the ankle. The most common osteoarthritis of the ankle is post-traumatic. And that's because once the cartilage is damaged, there's no going back. Unlike the knee and the hip that had that nice spongy kind of cartilage that gets worn down over the course of time, even if that's damaged, it can kind of make a little bit of a comeback. And that's why we kind of have this inverse relationship with patients that are younger developing osteoarthritis in the ankle versus the knee. Anyway, if we can kind of stave off that ankle arthritis by using protein concentrate, I think that that's certainly a future consideration. And that would go for the calcaneus subtalar joint and the talus, which is the worst bone in the body, in my opinion, because it's got the worst blood supply and it just destroys everything when it's angry. So if it rotates, it breaks the ankle. If it's dropped from a height, it breaks the calcaneus. If it breaks itself, it ends up with, multiple issues, whether it be non-unions or AVN or subtalar joint arthritis. Post-injection protocols. So again, I had talked about this in the previous lecture. Pre-operatively, I ask patients not, obviously hopefully they're not taking any anti-inflammatories prior to, but at least a week prior to surgery. And then 2 weeks post, they should not take, if they're going to get a PRP, should not take any anti-inflammatories. They are given narcotic pain medication, obviously for their surgery, and Tylenol, but ask not to take any type of anti-inflammatory. And yes, I get questioned from the anesthesiologist all the time if they can, can we give Toradol? And it's like, no, please don't do that. And they're like, yeah, but Dr. So-and-so does it. And it's like, yeah, but Dr. So-and-so doesn't give the PRP. It's going to just destroy that. Don't do that, please. So my post-op protocols obviously are determined based on what the procedure I'm doing. I'm an early weight bearing kind of guy. Most are weight bearing within a week, depending on what you're doing. Obviously, if you're doing something like a flat foot recon, you're not going to weight bear them in a week. But things that you need to get moving quickly, I try to get them non-weight bearing for about 5 to 7 days, and then weight bearing in a boot, and then out of the boot as quickly as possible. PT, I'll prescribe depending on the patient needs. If they can do a home exercise program at home, we'll give them that. If they are incapable of doing that, or if it's a procedure that warrants needing physical therapy, like total ankle joint replacement, then they absolutely get PT. I make sure to inform our physical therapists of what we did, including PRP injections. So in conclusion, there's a variety. I mean, you name the surgical procedure, you probably could use a PRP, a protein concentrate, or a BMAC in it. Not every procedure has great clinical evidence. Keep that in mind, especially the Achilles tendon. It's very interesting how the Achilles tendon doesn't repair that well, and I think it has a lot to do with its blood supply. And I had given the example of my friend. I'll just tell the short version of it. I play golf with a good friend of mine. He was a New York City cop and detective and worked his way up and busted like one of the big mob bosses in New York, and retired down in Florida, got bored, decided to go to work for the sheriff down here. I asked him, what the difference between being a New York City cop and being a sheriff down here was. And he said, to be honest with you, if you make a radio call in New York City, in 30 seconds, you have 300 cops at your side. If you make a radio call down here in the kind of rural St. Johns County, it's going to take 30 minutes for like two guys to come. So you better be darn certain that you're capable of handling those situation. And so that's similar kind of what happens with the Achilles tendon. So if you don't have the blood supply to get the signals there, so you're calling out on the radio to, hey, come help me, and you don't have anyone around, then it's going to take a little bit longer for things to heal. The beauty of the Apex kind of family of biologics is that they have kind of everything you need for each situation, and you can kind of make the combinations. I don't know, someone could probably do the math on how many different combinations. It's probably easy, of things you can do with the variety of. So you have PRP, both leukocyte rich and leukocyte poor. You have protein concentrate and you have bone marrow aspirate. So you can kind of combine those however you wish. Not one procedure has one indication for one type of, PRP or cocktail, if you will. So one size does not fit all. So it's not like I'm like, hey, Mrs. Smith is having a colectomy, so we have to do this, this, and this. It's not always the case. I will almost always use protein concentrate on any joint. That's true, but I don't always use PRP. I don't always use BMAC. It depends on the patient. The other thing you have to understand is you're using the patient's own biologic system. So if their biologic system is flawed, the system you're injecting, even though it's above, what they have, is still going to be lower than what you would normally, get out of the 20-year-old. So you say you have, Grandma Val that comes in and she's 80 years old and she's frail and she's osteopenic and she needs an ankle fusion, and you draw bone marrow from her. Well, she doesn't have as many stem cells as, say, I don't know, a 20-year-old runner that, has needs a first MPJ fusion because he fractured his met when he was skateboarding or something, that you can get bone marrow from. So just always kind of, obviously use good clinical choices, and you can, take from the evidence that I've given you. The one thing I will say is that I've been using more and more bone marrow aspirate intraoperatively. The problem with bone marrow aspirate is the morbidity associated with the even though it's a small little hole that you're creating. I can't tell you how many times people are like, my foot doesn't hurt, but whatever you did up here by my knee really hurts. And you get that a lot. But hey, it doesn't, their foot doesn't hurt. That's the most important part, right? But and like I said, you're never too young to learn. This is my little one, looking at stem cells. And not only am I a Apex Biologic user, but I am also a patient. So this was my partner, who is a Army West Point grad, played football for them. Very large gentleman, but very funny and great. Probably one of the best sports med docs out there. Does a lot of PRP. Needed to play in my annual golf tournament. That was kind of a big deal. Had a slap tear. Did not want surgery. Asked him to inject me. Did the protein concentrate and protein poor, leukocyte poor, sorry, and protein concentrate. And within a week, I was 80% better. Within 2 weeks, when I had to play the tournament, I was like 95% better. I still had a slight tinge, but the nice thing about this is I can tell my patients, listen, I had this done to me. I know that it works for me. At least it worked for me. And, I'm confident that it can work for you also. So, not only am I a user and a believer in it, but I personally tell you that it worked for me. And to this day, I mean, I had that done 5 months ago, and I still have no pain. I play golf like weekly. I live in Florida, so yeah, I'm playing golf like every other day, as much as possible. Not now because it's been kind of cold. And when I say cold, I know those of you that live in the north, you're like, yeah, whatever, that's not cold. It's like 40 degrees, 50 degrees here. It's too cold for me. But anyway, I left about 7 minutes for questions.
Yeah, thank you, Dr. Piraino. That was great. We appreciate it. We had a couple additional questions come in. One of them being, Have there been, to your knowledge, any reports of tendon rupture after injection with PRP or bone marrow?
I haven't come across any. That's a very good question. I haven't come across any type of rupture of any tendons. That being said, I know that, a common treatment for tendinopathies is dry needling. I think there's a handful of reports in the literature of possible rupture. I know that some of those like 10x procedures where they kind of cold blate I had one patient come in with a partial tear of the Achilles that if you just get a little aggressive with those things, they can certainly cause a tearing, but not with PRP. I mean, the needle you're typically using is a 21 gauge, and the way I inject it is kind of collinear to the tendon, not going kind of straight in and piercing it. So you're kind of just kind of bevel up, or bevel down, kind of going into that tendon and kind of filling it. But no, to long answer is no, I haven't come across anything.
Okay, great. Then the next one was you mentioned some post-injection protocols, but are there any protocols you have your patients follow before their injection to maximize platelet counts outside of stopping NSAIDs?
That's a great question. I really haven't thought of that, and I'm sure there probably is. And some of you that do a lot of PRP may do that, may have that, and I would love to hear that. I don't know if there's any literature to suggest that having them any type of nutritional, we have patients that, you can have protein shakes, and I have patients that, anytime they have any type of bone work, especially the ones that do the due diligence, will take vitamin D supplements and calcium supplements. But I haven't myself personally done that. But I'd be interested to hear if anyone else has.
Right. And then we also have, do you use protein concentrate with bone marrow concentrate as well?
Yes.
Okay.
I'll use PC and BMAC together if needed.
Okay, great. And then how do you determine when you will use PRP versus bone marrow concentrate interoperatively?
It's patient dependent, and B, situation dependent. Like I said, with the Achilles tendon, all the literature and all of our, what we were doing intraoperatively with PRP, it didn't make that much of a difference. But so that's when you're like, all right, well, maybe we need the cells. So that's when I'll switch to BMAC. So if it's overkill, then I'll just, if you have a patient that maybe a poor healer, you need to throw the kitchen sink at, that's when you'll use the BMAC unless it's some sort of fusion procedure. But if it's just a kind of standard, like the bunionectomies, like I'll never use BMAC for that because there's no reason to do it. It's a very expensive add-on. If it's going to benefit my patient significantly, that's when I'll use it. But and that being said, I mean, we use it a fair amount because we do a lot of kind of rear foot fusions and things like that. So I feel like I use it more. But if you don't feel like it's going to benefit the patient by getting those cells in there, and they're young and healthy and they're going to get it just with the PRP, then just use the PRP. It's like I said, it all depends. Like if you have someone that's frail and diabetic or immunocompromised and you're trying to give everything that you can to them, I'll use everything I can. If you have a 20-year-old athlete that wants to get back, that's not professional, that's like, a weekend warrior, use the PRP.
Okay, perfect. There's another one that asked, are there any specific contraindications or is there any reason why you would not utilize or follow through with a PRP or BMC injection?
No, I can't think of anything unless they have like some sort of leukemia or anything like that. Obviously but I mean, I had talked about this in the previous lecture. The beauty of PRP and BMAC is that it's safe and effective, and you can use it. I mean, you honestly could use it as many times as you want, in my opinion. I mean, obviously you have to use caution if you're injecting a tendon because you don't want to cause a rupture, but what's the harm in injecting growth factors into a patient multiple times? I'm not telling you to have patients come in and do it like every week, but there's literature out there. If you read some of the literature out there, they're doing 14, 15 injections over the course of a year, and they're getting some better results. So no, I don't think there's many contraindications. Obviously, infection, systemic infection, obviously anything that could compromise the injection, those would be the contraindications. But other than that, no.
Okay. Great. Well, Dr. Piraino, we wanted to thank you, and we also wanted to extend a thank you to all the participants for making today's webinar a success. We appreciate your time. We hope that everyone found these sessions very valuable. For everyone out there, we're going to make sure to get you a recap of tonight's webinar and include some of these studies and get that information out to you. So keep an eye out for that and for any future events. But until then, thanks again, Dr. Piraino, and we hope you
Yeah, thanks everyone. Appreciate it.
take care.